our own faculty, our own learners over the course of the year. So really encourage everybody to try to make it so that we can really support our own people giving presentations. We will take next week off and then begin our official scientifically oriented Grand Rounds presentation the following week. Dr. Quinn will lead us off. And this week, we begin with our education program. And Dr. Romero did really a remarkable job putting a lineup together of, I think it's 12 people who are going to talk right now. So everyone gets 5 minutes, and I don't have any Academy Award music or a hook or anything like that to make anyone stop. But everyone's been forewarned, and everybody here who's going to be presenting is amazing and could talk to us for an hour. So we're getting the best bullet points from people's vantage points, and hopefully this is helpful for everybody to know what's going on in the education world, which continues to grow. We also need to share much of this information because we need to share our action plans from various areas with the faculty. And again, thanks to Dr. Romero, who put all this together, who is also in PES at the moment, but will be joining us. Are you here yet, Dr. Romero? Okay, not yet. She put herself last. So I think she's anticipating joining later, and as she's actively working in PES right now. So we're going to go ahead and start, and I'm going to turn to Dr. Dellmore. People are going to have been made co-hosts so they can share their own slides and help us see stuff. So Debbie, thank you.
Thank you, Jeff. Appreciate that. So good to see everyone. I'm excited to see so many residents here. Thanks for that. Okay, I think I can keep this fairly brief. I'm Debbie Dellmore, and this is your medical student update. So first, I just want you to take a couple of seconds to think to yourself about why teach? Why do you teach? Well, I've got an answer for you. It's because it's fun. It drives joy in our lives, and it will improve patient care as well. It's good for you. It's good for our learners. These are some student quotes from their experience of your teaching them. The psych residents are awesome. I can't highlight that enough. I've heard that over and over and over again here in the last few weeks as I've met with students to do their midpoint feedback sessions. I feel like on psychiatry, I contribute. It's a safe and supportive environment. It's a welcoming environment. Faculty and residents are excited to teach, and everyone treated the patients with respect, even in challenging situations. So I'm really proud of my colleagues, and I'm honored to work with you all. So this is what I hope you get out of the next 1 to 2 minutes. You've already accessed your motivation to teach. I want you to know who to contact if you're concerned about medical student education. Think to yourself what you want your students to learn, what should be expected of them while they rotate with you, how to assess them, and then just a couple parting thoughts about promoting resiliency, which we now know is so important to our ongoing health and wellness. So I'm the director. I'm really honored to work with Dr. Valles as my associate director, and our new to the clerkship, Dr. Armijo as assistant clerkship director. So we really hope that students, when they do their rotations with us, that they have an opportunity to decrease whatever stigma they may have around serious mental illness, that we hope that we prepare them as doctors to be able to evaluate risk in their patients, and that we expose them to the benefits of using buprenorphine therapy for the treatment of opioid use disorders. We also hope that they take away their good clinical skills, primarily communication skills in the interview, in the mental status exam, in coming up with psychiatric differentials, and then of course the biopsychosocial treatment plans. So what are they doing now on clerkships? Students have 6-week blocks now, but 2 of those weeks at any 2-week component belong to another rotation where they do some exploration of their clinical interests. So we have two-week sub-rotations within 6-week blocks. So all students will rotate for 2 weeks through either the adult or the geriatric units at UPC. And then they have a 2-week elective experience where they can choose from either the VA, child inpatient, or SRMC consult. They also do 2 shifts in PES, and they do 1 clinic either at ASAP or Recovery Services of New Mexico. These, I have to show these to you. These are the clerkship objectives. What should you expect from students? We expect them to see their patients and be involved in patient care while they're with us, to write notes, to present their findings in treatment team and collaborate with the team. And then finally, to look up and present a critical appraisal of a primary research article, to practice their evidence-based medicine skills, and also to teach you as well. These are the required patient encounters. I also am required to show this to you. They're what you might expect. So I ask each of you, as you are committing yourselves to the joy of teaching, to also commit yourselves to providing timely, specific feedback for your learners. When you assess your learners, remember we use the PRIME tool, and remember to, when you check off the behavioral anchors, to keep in mind where your student is functioning most of the time, and then write a narrative. So narratives are helpful if you focus on highlighting the competencies of the student. And if you can give me specific examples of student met with a very complex patient and established rapport, or student did this or that, it really adds to their final write-up. So at the end of their 2 weeks with you, I ask that you please, the most important thing is that you check off the behavioral anchors in the professionalism, reporting, interpreting, managing, and educating, the PRIME areas, and that you write a very brief narrative. You do not need to rate the student numerically in any way. I take care of that for you. The most important thing is to choose the behavioral anchors appropriate to them in each of the categories, not to go down all expected or all advanced, but to highlight each area and then to write a brief narrative. And then finally, before I part, I want to remind you about some of the newer sort of obvious logical evidence we have around resilience, but I think it's good for our learners and it's good for us too, to remind ourselves to try to do what we can to promote a safe environment, which we're already doing a good job of. So keep up the good work, to be aware of emotional intelligence. Also, we're pretty good at that with our communication skills, and to help students have a sense of control over their own learning and clinical experiences. And then, to stay positive. So with that, I appreciate your time, and I will turn things over, I think, to Dr. Smart is next.
You know what? I want to do a little bit of a change in the order, if that's okay, Lindsay. Just okay. Dr. Romero's with us right now, and who knows, it's busy in PES. So if we can let Dr. Romero go, and then we'll get back to our order, if that's all right. Liz, you're on.
Thank you. Can you all hear me okay? Okay, sorry guys to switch up the order. Of course, as it when grand rounds is happening, PES gets really busy. So I'm going to briefly share with you all the action plan for this year, so that you can know kind of what our direction is going forward with the residency, and also to get your feedback and approval or disapproval. So I'm going to find my slideshow here. Just give me 1 second. Okay. Let's see. Okay. So the action plan, of course, is born out of the PEC retreat, and we take our data from the AC GME survey that we get every year from both the faculty and the residents. And I know we're short on time, so I am going to kind of race through this. So we identify from the AC GME survey the areas in which we had lower scores to identify our focus for how we want to improve. And this is these are the areas, just briefly, that were identified this year. First of which is creating an environment of inquiry, which is something that we've tried to improve over the years that continues to be an area that we can improve more. In the PEC retreat, what we've tried to do is concretely identify a problem and then a proposed solution, as well as the folks involved in that proposed solution. For creating an environment of inquiry, this one's fairly straightforward. It's just we want to increase resident awareness of academic pursuits within the department. Our faculty do a lot of amazing things, and we want to be able to involve our residents in those academic pursuits. And so our proposed solution is the creation of a map involved.
The god of Zoom is talking to us.
The next area is feedback. And feedback is just always a tricky one. We consistently each year, that's something we want to continue to improve. A few of the problems concretely identified were inconsistency between the midpoint and the final feedback sessions. Residents expressing that they felt like they weren't observed enough by faculty and would desire observation, and also helping our residents with the tools to elicit feedback. And so because feedback is kind of a big one, it's a bit of a beast, and I think it's a complex and really, really important issue for us. We are planning to form a subcommittee of the PEC specifically to address feedback. And so if anyone out there is excited to get involved, this is also an opportunity for you all as faculty to know the areas we're working on. And if you would like to get involved in a subcommittee, please let me know. We would welcome everyone's ideas. Diversity and inclusion. A problem that was identified is that there's a lack of a formal diversity, equity, and inclusion curriculum, within our resident didactic curriculum. And so thankfully we have the wonderful Dr. Smart within our department, who is a great resource for DEI in working with the UNM Office for Diversity, Equity, and Inclusion. And so as part of our education subcommittee, we have included in that a working in of a more formal curriculum within the larger didactic curriculum to address this issue. Which brings us to our didactic curriculum, the educational content. So as you can see, this is a pretty busy slide. So lots of specific areas that we would like to address in terms of our didactic curriculum. As you can see, better defined goals and objectives. Some of the feedback we've received from residents is that they would like to see more of a progression from year to year in the content of the curriculum. Bringing ourselves into, the technologic age with online and self-study resources available, as well as a timely mechanism by which residents can give feedback about the didactics they are receiving. And then as well, formalizing some of our educational experiences within the rotations. And a lot of this is actually already happening. So many people, Dr. Quinn, Dr. Yaya, Dr. Siebert, all of our chiefs have really put a lot of energy into developing case conferences and more formalized curricula for the specific rotations. So I really appreciate everyone's effort. This is already under education chief resident, Dr. Wales, has put a ton of energy into the education subcommittee. They are meeting regularly, making changes. Dr. Canaca has been involved in overseeing this whole process, as well as Dr. Katzman. So that stuff is underway. We've got a lot of energy for that. So thank you everyone for your hard work on that. And then another area identified on the survey was a sense that there was a lack of data about outcome measures in terms of retention, recruitment, diversity, where are graduates ending up. And so I think this is a fairly straightforward solution that I'll work with administrative staff on, just in terms of consolidating the data that we already have for where our graduates end up, and kind of maintaining contact with our alumni and using their experiences to help broaden the horizons for our residents currently. And then also our plan is to create an exit survey, a more formalized exit survey for our graduates, so that we can get some very useful data as people sort of reflect on their training time here. clinical experience. These are a few things that have been going on. The lack of continuity experience in the PGY2 year has been an issue that has come up for the last few years. We're still sort of in process in terms of how we can logistically work out possibly a continuity clinic type experience for the PGY2s. Residents feeling that they would like to be more involved in crisis call debriefings, which is happening. Again, there's been a lot of great energy from faculty and residents alike in terms of safety. And so this is already in the solution mode. Non-clinical task burden for residents. This is also already in the solution mode. Residents and faculty are meeting regularly with our really great administrative staff in the various clinics to try to brainstorm ways that we can be more efficient and create more time for learning and have less of an administrative burden for our residents who are working really hard. And then billing, of course, and I can always use more training on billing. So we're trying to incorporate billing training as part of orientation to each year, as it may differ depending on the clinical site. And I think that was it. Sorry, that was like fast. I appreciate it. I want to be mindful of our time, but maybe just take 1 minute to see if there's any sort of immediate feedback. Dr. Katzman, I'm not sure how we should vote on this, if I should send this out and we can vote by email whether or not to approve this action plan.
One way would just, if somebody doesn't approve of the action plan, they could just put no in the chat.
Dr. Katzman, if I can make a comment here.
Absolutely.
So this is great, Dr. Romero. Very clear the problem and a solution. The problem is very clearly described and the solutions are achievable. I also think that the input of residents is very valuable for the department and the treatment of our patients. And I can tell you, I experienced that during COVID. The times that I got the most out of the challenges that were experienced was meeting with our residents, not only how to best treat our patients, but also how to make the administrative process be more user-friendly. So all your problems with the solutions are great. As always, terrific job, Dr. Romero. Thank you so much.
Thank you.
Thanks, Dr. Tohen. Liz, that was just my one little idea to make it a fast process, but the other thing would be just for you to send it out and people to vote thumbs up or thumbs down, whichever you want to do.
I'm happy to send it out. I know I sort of flew through it, so if folks are interested, I'm
Cool.
totally happy to send it out, and then we can vote that way. Thank you all so much. I do need to get going, but I really appreciate your time. Thank you, thank you, thank you.
Thank you. Thank you for setting this up, and thank you for being here. Thank you. Dr. Smart, you're on our internship.
Fantastic. I would like to share my screen. Let me do that. So with the time that I have today, what I'd like to focus on for the internship is to just reorient folks to what we do and who we are, and to share some information about the demographics of our faculty and our alumni, as well as a little bit about our applicant process this year and the pool that we landed with in the match process. And then just a few updates about what we're doing in the internship this year. So for those of you who I haven't met yet, although I think I've met most folks, my name is Lindsay Smart. I'm the training director for the internship training program. Our internship crosses a lot of different systems here at UNM. And so some of that I'll talk a little bit about with our faculty. We have 7 tracks within the internship training programs that folks match to. Those tracks are autism spectrum disorders, early childhood, substance use disorders, multicultural Native American and rural track, integrated behavioral health, child clinical, and pediatric neuropsychology. So every year we go through a similar process as the residency of interviews, the utilization of the natural MASH service, and then match through hopefully a phase 1 approach with 12 interns each year. So our little bit about our faculty as it stands today, you can see a little bit about our demographics. 76% are female, 24% are male. The majority of our faculty do identify as white. The next would be Hispanic, Latino, 2 or more races, Black, Asian, and then American Indian or Alaska Native in those percentages listed there. Some of our faculty do identify as being what APA categorizes as a foreign national, and 5% in that category. Our faculty tend to have a degree in the clinical psychology domain, but there's other degrees that are represented among our faculty as well. Our faculty are across the Department of Psychiatry and Behavioral Sciences, Department of Pediatrics, hospital staff, as well as the Department of Family and Community Medicine. Our internship alumni tend to match our faculty fairly closely in demographics. 84% of those who have graduated from internship in the last, probably captures about the last 10 years, are female, and 16% are male. The largest proportion continue to be white identified, with the next percentage being Hispanic Latino. Our APA also collects information about disability status. And so you can see here, we've got about 3% of our internship alumni that identify with some disability. So that's a little bit about our faculty, and we continue to work to update this data pretty regularly on an annual basis. A little bit about our process this year and our applicant pool. We had 188 applicants for our 12 slots. We interviewed 119 and landed with a matched pool of 12 individuals. Our applicants this year largely were female, again, 83%, and 11% were male. At the early phases of our application process, APA does not collect race ethnicity data, and they're sort of piloting whether they will do that after the match or before the match. So I don't have those statistics available yet. Most of our applicants are coming from a few states: California, Texas, Colorado, Illinois, and Pennsylvania primarily. Some of that I think is demographic, and the emphasis that we put on bilingual patient populations, and some of that is, I think, due to the history of the program and where we've recruited applicants from in the past. About 12% of our applicant pool this year were bilingual in Spanish. Probably about 15 to 20% were bilingual in some language, which could have included Spanish, also included other languages as well. So our recruitment process this year, the past cycle for the class we just matched, was all done virtually through Zoom. One of the processes this year that we'll be talking about as a training program will be the continuation of a virtual versus a non-virtual recruitment process. One of the processes that we're looking at is the economic and financial equitability that is implied by having a virtual interview process to save our applicants thousands of dollars from traveling across the country, if not the world, to find a slot. So that's in our big decision process and updates for the next few months as we get ready for our next recruitment cycle that starts in November. We have a site visit. We are up for our APA accreditation, and so it was delayed due to the pandemic, but is finally happening this fall. And so there will be a large administrative push to get everything in place to ensure that the site visit goes well, and hopefully we receive 10 years of reaccreditation. We also have some innovative social justice and DEI initiatives that we're trialing this year. We're doing a book club with another internship program at Louisiana State University. We're reading, I'm forgetting the name of it, but a book related to medicine and social justice issues. And we are doing that through our seminar didactic schedule as a further way to continue to indicate for our accreditation, as well as our commitment as an institution to DEI efforts for our learners. So I think that those are probably the big updates that I have for our internship training program, and always look for opportunities, just medicine, thank you, Jennifer, for bringing all discipline learners together in some of these activities as well. So Thank you. And I am not sure who goes next, Jeff.
I
So
got
I'll
it.
let you pass the baton.
Hey, Lindsay, thank you so much. I feel like we could spend an hour with everybody just with questions and answers and learning more. Maybe we should figure out a way to do that over the course of the year over lunches or something, because there's so many questions that I have, and I'm just one Zoom cell. So thank you, Dr. Smart, for that presentation and for all the information. I am now going to hand the baton over to Dr. Sowar to talk to us about our child fellowship.
All right, thank you, Dr. Katzman, and it's a privilege to follow the individuals that have spoken thus far. We're grateful in child psychiatry to collaborate a fair amount with Dr. Smart and the psychology interns. So yeah, I'll follow suit. Let me go ahead and share my screen then here. So yeah, some color hopefully for the slide this afternoon, and we are just going to spend a little bit of time talking about child and adolescent psychiatry, the fellowship, and also some of the experiences for our general residents. Yeah, so I'm grateful to be with you all. I also am here to represent our other faculty in the child division, including Dr. Timothy Kane, who is our associate program director. So yeah, just a few images thinking about New Mexico, thinking about child psychiatry, and why we feel like this is an important piece to include today. So why child psychiatry? Why do we encourage people to both maximize their training during general residency and then think about the fellowship? So I've included some of those ideas here. One is expanding skill set and comfort in working with kids, families, and adults, developing more kind of knowledge and comfort in early and preventative interventions, really being able to care and advocate for a vulnerable population. And then again, expanding understanding of things that are pertinent to both children and adults with regards to attachment, development, family and social systems, et cetera. So this slide here, the map is kind of small, but as you can see, the general trend, which is in red, reflects significant deficit, really underserved areas pretty much throughout our country of child psychiatrists. When you look at the number of children who meet criteria for a mental health disorder, so children under the age of 18, up to 20% do, and only about a fifth of those are able to receive care from a specialized provider like a child psychiatrist. And then on the flip side, when we think about how many of the mental illnesses that we see in adults have started in younger people, about half are by the age of 14 and 3/4 by the age of 24. So this is a really vulnerable and important time for us to be able to provide our best care. This slide here, I think, is intended to highlight especially why in New Mexico, we feel like being able to target children and families with excellent service that we can provide is important based on poverty, based on levels of trauma. And as you can see here, some of just the markers of child well-being around school performance, economic situation and such. We know that New Mexico is a vulnerable place. Okay, so just to transition then and talk a little bit about child psychiatry training for our general residents. So starting during second year, all of our residents do at least 1 month of inpatient at the child psych hospital, and then also have some selective opportunities, which could include research. Third years do a year-long outpatient continuity experience, and then fourth years certainly have elective opportunities. And for all years of general residence, we hope to foster work with children and families through the PES experiences, therapy patients, and other didactic education and mentorship opportunities. We are very excited about having a child track as part of our residency now. So we have 3 full classes of child track residents. So there's 2 per year. It is a separate NRMP match, and these individuals do 3 years of general residency and then 2 years of fellowship. There are a handful of other programs around the country that do this. Dr. Sidhu, the previous program, Dr. here got it started, and we're just very excited about having it. So our child track residents have some additional opportunities to do child-related training in their first couple years. And we're really working on expanding, including with the help of the current child track residents, on expanding some of our joint didactic opportunities and clinical training as well before people enter the fellowship. So then our fellowship in and of itself is a 2-year program. associated board eligibility upon completion and with the board exam. And we've been training fellows for a pretty long time here in New Mexico, so have a strong track record. Our current size per ACGME allotment is 8 spots, and we currently have 5 fellows this year. So we have 2 second years and then 3 first years that we're really excited to have welcomed this week. We're also really excited that we have 5 commitments for people starting in next year's class. So that'll continue to be filling our fellowship positions. And there are a few different routes to getting to a child fellowship. So we mentioned the child track, but then for those people doing a general residency, you can complete all 4 years and then do a fellowship. You can fast track into child after 3 years of general residency. And then at UNM, we offer an early commitment, as we did this year, where residents who are interested before the match are able to make a commitment to our fellowship program. This here just highlights some of the variety of training opportunities for our child psychiatry fellows. The first year has a mix of inpatient, consult liaison, and then some outpatient opportunities that include urgent evaluations, neurodevelopmental disorders, and such. There's also ongoing didactics throughout the year with a full dedicated day to didactics and psychotherapy. And then as you can see, the second year curriculum here is very broad. There's a lot of elective opportunities. We're really fortunate to connect with our other subspecialty areas, including addictions, women's health, some of the other areas mentioned here to provide, including other flexible options for fellows as they're interested. And then throughout fellowship, we also really focus, as mentioned, on education. So with the didactic day and really just trying to make the most of the very dedicated group of faculty that we have with regards to ways we can expand education, both locally and through connections nationally. I think that been one of the nice things with COVID is more ability to connect virtually nationally. And then certainly also on this consideration of wellness and promotion of wellness amongst our fellows, including capping our call schedule, fatigue mitigation, and then active feedback and committees to help improve our fellowship process. So this here is just reflecting our leadership. Again, myself and Dr. Kane with the program director roles, and then I've mentioned other important faculty in our division in these different houses, although of course we really value all of our child faculty and the tremendous amount of teaching and clinical work that they provide. And as far as changes and updates, we've had thankfully really positive ACGME survey results. We're continuing to expand our training in neurodevelopmental and family therapy realms, and just continuing to work within other elective, other didactic areas that we can strengthen. So that's overview of the Child Fellowship. If any of you are interested, those of you interested in fellowship, please feel free to be in contact with myself or any of our child faculty. Those of you that may just want to get stronger child training and not do the fellowship, we're always happy to create additional opportunities too. So really appreciate the opportunity to be here today and join this great group. And I believe Dr. Valles is next, but I'll hand it back to you, Dr. Katzman, just to make sure I'm correct with that.
You're correct. And thank you so much for that presentation, Dr. Sowar, and I'm handing over to Dr. Valles to talk about our psychosomatic fellowship.
Thank you. I just need to figure out how to share my, here we go. Okay. So if you guys can hear me and see my screen, my name is Emiliano Valles. I'm one of the consultation liaison trained psychiatrists here at the University of New Mexico. And I'm the medical director for the Adult Inpatient Consult Psychiatry Service. We are involved in the education of residents kind of throughout the course of their training, both during their PGY1 and PGY2 year, where every resident gets the opportunity to rotate with us on service here at UNM Hospital, and then also gets the opportunity to rotate at our VA location with Dr. Geppert, amongst a number of other clinical trainees from family medicine, from internal medicine, from neurology, physical medicine, and rehabilitation. And so all of our residents will get the opportunity to rotate with CL during their training. However, today I'm going to be talking about our fellowship in consultation liaison psychiatry. which is, at least the last time that I checked, the most recently approved kind of psychiatric subspecialty according to the board. But to be honest, it's an incredibly old consideration in the field of medicine. The idea that the psyche and the soma are integrated and interrelated, and that impacts on the one affect the other. And so in the field of CL psychiatry, we definitely focus on psychosomatic medicine, which is an emphasis on how psychological factors might affect physical conditions. And so things along the lines of conversion disorders, somatic symptom disorders, illness, anxiety disorders. And we also focus on how physical conditions often affect psychiatric symptomatology, with the underlying kind of knowledge that both cognition and emotion are informed by underlying physiological processes that are impacted by medical illness and impacted by psychopharmacology, with the understanding that the brain is a massively multimodular organ that has kind of a well-defined functionality with highly specific inputs and output that is somatotopically mapped. And theoretically, you could predict impact on cognition and behavior based on lesion location. And so we get to nerd out about some of that stuff pretty regularly. But our bread and butter is the consultation and liaison aspect, which is helping to manage psychiatric patients encountered in a general hospital medical setting. And so why do we emphasize kind of training in consultation liaison psychiatry? In part because, in my opinion, CL psychiatry is the future of psychiatric clinical care. Unfortunately, there will never be enough mental health providers to cover all of the needs for our psychiatric patients across our country. And so our colleagues in family medicine, internal medicine, pediatrics are often going to be carrying the majority burden of clinical care for many of our patients. And I believe in meeting our patient population where they exist. And so to some degree, collaborative care models, kind of registry management, step care approaches may be the future of psychiatry. And I also feel like care extension models can be the future of psychiatry, working alongside advanced practice providers, psychologists, in order to leverage the medical expertise from psychiatry in order to provide kind of optimized care. Now, this can be challenging, and in part because after the first year of residency in psychiatry, a lot of our trainees are segregated away from medicine as a whole for the rest of their residency training. And so even though we know that the psyche and the soma are integrated, we don't necessarily treat it that way in education. And, you know, our psychiatric hospital is literally across the street from the rest of everywhere else that provides medicine at UNM. And so we have to kind of overcome that separation and the stigma. As psychiatric clinicians who have been away from medicine, the question arises, do I know my stuff? Am I a doctor technically? And we have to overcome the stigma from other aspects of medicine, kind of viewing our field from an outside kind of stance that may not understand exactly why it is we do what we do. So why overcome this? In part because being comfortable functioning and communicating in a medical environment is becoming increasingly valuable. And so many of our patients are having kind of more complex and more difficult medical issues that alongside psychiatric symptomatology, and we have to feel comfortable caring for that patient population. Many of our trainees in other walks of medicine need to be provided with kind of introductory rubrics and approaches to clinical care for psychiatric aspects of patient care. And in part, it puts us in a position in psychiatry to really emphasize and improve the value and visibility of our field. We get to be the face of psychiatric clinical care to the rest of medicine. So how do we overcome that barrier? In part, by providing training for the next generation of consultation liaison psychiatrists. And so we really kind of emphasize the interface between psychiatry and medicine. And as medicine expands, that the volume of that sphere of knowledge is ever increasing. and the touch points between psychiatry and medicine continue to grow. And so training our students to be at that interface and at the forefront can help us to be on the cutting edge of psychiatric clinical care moving forward. And so CL psychiatry is something that provides us the opportunity to really get back into medicine and kind of return to the bedside, recognizing that the history of psychiatry, came from neurology. And when our physical exam and evaluation was inadequate, we needed to expand our ability to provide a mental status exam. But that doesn't discount or negate the utility of being at the bedside and adding to our mental status exam a lot of those physical characteristics that can increase the yield of our clinical evaluations. And so to do that, it takes pretty intensive exposure to many, many patients over the course of a 1-year full-time clinical fellowship. Residents are provided PGY-5 pay scale. This is an HSD GME accredited fellowship. After graduating, you may sit for a subspecialty board evaluation exam, and then that qualifies you to potentially initiate and continue other CL programs or fellowships. Basic requirements to apply: board eligible, PGY-4 in good academic standing, partial or full licensure in the state of New Mexico, DEA, New Mexico Controlled Substance License, CV, a program letter, as well as 3 letters of recommendation. And what to expect on CL fellowship rotation. Our students can expect to spend 6 months here at UNM and 6 months at the VA. At each clinical location, you will be expected to rotate on the inpatient CL service daily, but have the opportunity throughout the week to kind of attend primary care integration clinics, subspecialty clinic kind of experiences, as well as here at UNM being involved in some of the ECHO project clinical case conferences. This is an example of our weekly schedule. You can see that residents would be pretty busy and have a lot of exposure to a lot of different kind of clinical care environments. The faculty that we have currently, this year I am the Assistant Fellowship Director, and Dr. Brent Hager, who's also on Zoom, wave hi Dr. Hager, is our new Fellowship Director. We still have with us Dr. Quinn, who initiated the program, as well as Dr. Geppert, the site director over at the VA, former graduate Dr. Timothy Kane, and we also have adjunct faculty, including Dr. Higgins and Dr. Christensen, helping provide education. Perks of the fellowship, for us, it's kind of being well prepared to be at the forefront of psychiatric clinical care at the interface of psychiatry and medicine. Residents or fellows will receive PGY-5 kind of salary, benefits, health insurance, etc. And I'll go ahead and skip ahead. Thank you all. I hope that we continue to encourage interest in the fellowship.
Great, thank you, Dr. Valles. We're going to turn to Dr. Romo now. It looks like to finish on time, we all have 3 minutes. So here we go.
Hi, I'm Paul Romo. I'm going to make it 2. The Addiction Psychiatry Fellowship's pathway to become an addiction psychiatrist. Once you get that title, you'll immediately be connected, especially in a state where there's so much suffering on multiple levels. And that's from state leadership all the way to within our own organization at UNM. The director is Snehal Bhatt. You're welcome to reach out to him. You're also welcome to reach out to me and get in touch with me if you have any additional questions. But it's a mixture of outpatient and inpatient experience, a mixture of UNM and VA. And we'll also get you up to speed on pain management, which is one of the threads of addiction psychiatry. I've loved this field. It's brought me close to a lot of you, a lot of patients, and you can really make a difference throughout the entire state as well as our community. We would love to have you in our ranks. And I know you got a sample as PGY-2, as a PGY-3, but this is where we'll give you a really concentrated version of it, where you get to explore all the evidence-based tools that we have. And we'll also take you into the qualitative level of it so that you get a better understanding of self and therefore can give your patients a stronger level of empathy through what they're going through as you walk in solidarity with them through their suffering and their recovery. All right, thank you.
Beautiful, Paul. Thank you so much for that. Dr. Higgins, you're on.
All right, can everybody hear me? Okay, okay. Sorry, let me get back here to the right beginning of this. Okay, so I'm Dr. Higgins. For anyone that doesn't know me, I'm the Fellowship Director for the Reproductive Psychiatry and Infant Mental Health Fellowship. We treat women with mental health disorders in times of hormonal transition. The majority of what we see is women in pregnancy and postpartum, very, very common. For example, postpartum depression, postpartum anxiety will affect 1 out of 5 women, so much more common than people think. So that is the majority of the patients that we see, but we definitely see women who are having issues related to their menstrual cycle, and again, in the postpartum period. We also have rotations in infant mental health, which really focuses on the attachment between primary caregivers and infants and young children. I am mostly oversee the reproductive psychiatry portion of the fellowship. That is my expertise. The infant mental health fellowship, I have wonderful help from 2 psychologists who are wonderful from the CDD and Department of Peds, Peggy McLean and Julie Oppenheimer. I think this is a really exciting and rewarding field to be in. It really is a chance for us to be preventative in our care. We know that we are going to reduce the risk of mental health problems in children if we can treat mental health problems in their parents. So it's been a really rewarding field to be in. So the structure of our fellowship, it's a year-long fellowship, not currently ACGME accredited, but I do believe that we are moving in that direction. We have 1 fellowship spot available per year. It's open to psychiatry residency graduates. Your time will be split between perinatal rotations and infant mental health rotations, and that can be tailored to the fellow's interests. For example, Simi Brar, who was our first fellow in 2019, she had already done a lot of perinatal work before even coming to the fellowship, so she focused a lot on infant mental health in her particular fellowship. We will also provide training in psychotherapies, evidence-based in these 2 populations. You will also have an education experience or scholarly project that you will have protected time during your week to do. There will also be electives outside of the perinatal and infant mental health rotations. Some examples of that would be gynecological cancers, endocrine, lots of different places that we could also do some additional work. We have a weekly didactic series where we do not only sort of the normal lecture, but we also have journal club, case conferences. The other thing that's really exciting about our didactic series is I am in a collaboration with several other fellowship directors around the country, and we're trying to standardize our curriculum to try to move us to become ACGME accredited, but we're also going to be doing didactics for all of our fellows together. So you're not only going to get sort of local expertise, you're going to get expertise from around the country, which I think is very, very exciting. So our program is unique in that we're the only one that does combine a reproductive psychiatry fellowship and an infant mental health fellowship in 1 year. You can find them both separately, but I believe we're the only one that has a combined program. What's a little bit different about our fellowship compared to some of the others is the fellow is hired as a visiting faculty member instead of a traditional fellow. That means that the fellow can bill independently, and they can also supervise trainees and sign off on their notes as well. So I'm going to stop there, let the others ahead of me have their time, but please just reach out to me if you have any questions at all. I'm always happy to answer them.
Thank you, Dr. Higgins. Turning to Dr. Pentz.
Here.
going to see if I can share my screen here. All right, here we go. Hi, can you hear me okay? Okay, I'm Dr. Pentz. I'm a child and adolescent and adult psychiatrist. I actually did a 4-year track instead of the combined that you're describing. Let's see if I will advance. So I've been the program director for the Integrative Psychiatry elective that we have, but it was on the shoulders of Dr. Arinello and Dr. Lynn that this helped to be created, as they had an elective 2 years prior that was like a 2-month elective. Because of Dr. Arinello's support through the department, we've been able to continue for the last 2 years, and I'm hoping to continue beyond this coming year. The resident, as well as interested faculty, do have access to the University of Arizona online integrative medicine psychiatry curriculum, and the response to that has been really positive. Let me move there we go. So this is the 3rd year now that we've been working the program. We had 3 residents the first year, steady attendees. We also had people, I need to let you all know that you all are welcome to join as you would like. It's not mandatory in terms of you have to come every week. So if there's a topic of interest, do join us. And with the Zoom option, which is now a permanent option for us, you all can join us as you would like. The meeting initially was an hour and a half, but then we moved it from Monday to Tuesdays at 4 to coincide with the didactics of the residents, and that actually helped to improve the attendance. Some of the topics that we cover in the beginning is an 8-week course on mindfulness meditation. We also do at least a 5-week course on nutritional psychiatry. You learn about breath work and yoga. There'll be an introduction to Ayurveda and Chinese medicine. This year, we actually had a COVID-19 focus with that in mind. There's also an opportunity to participate in a 2-week course in the summer to meet with healers from all traditions from an Indigenous perspective. There's exposure to arts and medicine, which is a program that we have at the University Hospital. There's also exposure to herbal medicine and hypnosis. This past year, we had 7 residents. We were able to do some things despite the restrictions of Zoom, but I know there were many limitations related to that. I did have a small grant that I was able to work with Dr. Crisanti and the team. It's the first time as a PI. It's going to continue through September due to the issues with COVID. I was able to pay some of the community practitioners that had volunteered time, and I was to have had 2 wellness retreats on the weekend, but we'll postpone one to the fall this year. And there's an opportunity actually for each resident that signs on to the elective of $100 to participate in yoga or all other wellness classes in the community. There were some grant challenges that I won't go into right now. The response has been really positive, especially around the mindfulness meditation. The next steps, I'm hoping to incorporate in either the continuity clinic with the 4th year or the psychotherapy clinic to allow for an introduction of the concept of integrative psychiatry with supplements as well as mind-body medicine. And a group case conference approach is also going to be sought out. For the most part, it's been a really positive experience. I know due to COVID, we've had some restrictions in terms of meeting in person, but we're hoping to be able to do that this year. This program is still available for those. We have 5 people that have actually agreed to join this year as an elective, and would welcome you. And please reach out to me. I'll put my information in the chat and give over the stage to the next person. Thank you.
Dr. Canaca, you're on.
Thank you, Dr. Katzman. And Dr. Crisanti, do you want to go first? I don't know if we have enough time, and it is okay if you want to go.
No, go ahead, Jose. Thank you.
Okay.
I can talk really quickly about the research track.
Okay, I'm gonna share my screen, and I'm gonna try to do it in 2 minutes. Can you see the screen, my screen? Yeah.
Yes.
Okay. So this is the, let me give you. So this is a big group, the community and rural track. So I just want to say thank you to all of them. They work really, really hard to offer this community and rural experience to our residents. Just to share a little bit about the community rotation, we have a really nice group of supervisors. We have Dr. Bonham, Bolton, Rosenbaum. Now the residents will have a new experience with Dr. Sowar for the UNM Eating Disorder Clinic. Thursday, they spend time with Dr. Hager, and Friday for Sandoval Regional Medical Center. This is only for the PGY2s, and every single one of them do this rotation for 4 weeks. We have two, they present, they give 2 talks to the communities during this experience, the community. One of them is for the CIT ECHO, that's for the law enforcement, for police officers in New Mexico, and sometimes we have police officers from other states. And also we have the Rural Psychiatry webinar series, and this is for rural mental health workers in New Mexico. And we have 3 experts, 3 mentors. So those are Dr. Crashman, Dr. Folder, and Dr. Fairfax Colombo. These are some of the topics for this year for the rural webinar. We have the rural track, and this is possible because of the generous collaboration from the Human Services Department. These are some of the sites for the rural track, and Zuni Pueblo and the state hospital is very active. We have good reviews from those places, and we also have Las Cruces and Alamogordo. And the last piece I want to share with you is the Human Services Department GME Expansion Program. So the state is putting a lot of money to develop new programs in pediatric, internal medicine, family medicine, and psych. Dr. Tean is one of the board members, and Dr. Romero and I are advisory group members. So next year, we're going to have a new psych program in New Mexico. That's going to be in Doña Ana County, Las Cruces. And by 2024, we're going to have a program in Gallup, I believe. Thank you.
Thank you, Dr. Canaca. Dr. Crisanti, bring
Right.
us home.
Okay, I am going to, well, people who know me know that I talk fast, so I'm going to talk really fast. And I'm also going to share my 2 minutes, I guess it is, with Danielle Farrar, who is PGY4, who I've asked to talk a little bit about the research track. So I'm just checking everybody can see this PowerPoint. Yes, thumbs up. Yes, okay, I see a couple of nods. Okay, so there's lots of opportunities. Let me just, there we go. Oh, shoot. Trying to, there we go. There's a variety of options for participating in research in the Department of Psychiatry. And I kind of think about a continuum where you can kind of just get your feet wet and collaborate on existing research that's going on in the department. You can get involved in IRB development or participant recruitment or collecting data, collaborating on manuscripts or presentations, and there's lots of sort of kind of different opportunities in between these 2 spectrums. But on the far end, with respect to residents, we do have we used to call it the research track. We're switching over to calling it the physician scientist track, where it's a much more structured program for residents who are really interested in becoming a physician scientist, where they'll get all the same opportunities that I described earlier, but really focusing on encouraging them to become an independent researcher once they complete their residency. So in terms of the different types of research in our department, we kind of have 2, I guess, sort of streams or focus, I guess. We have the Center for Psychiatric Research, which we kind of see as the experimental kind of research hub of the department. And then we have CBH, that stands for the Division of Community Behavioral Health, which really focuses on mental health services research and evaluation, much more community-based, and a lot of partnerships with the state. So just a couple of other things that are important for you all to know about research in the department. We do have our annual research showcase. We had our first one last year. That was in November last year. So hopefully we'll aim for November this year. We also have developed a research sort of report that highlights all of the different research activities going on within the Department of Psychiatry. So I encourage all of you to get a copy of that reach out to me if you don't have a copy. Really review it because it's really quite impressive to see all the great work that our research faculty are doing. We also applied for an R25 grant for NIMH to fund the physician scientist track. We should know by, I'm hoping, the end of this year whether or not we got funding or not. This was a renewal, not a renewal, so we revised our first application and submitted it with hopefully addressing all of the concerns that were identified in the first go round. And just, I really want to encourage faculty to, kind of going back to what Dr. Romero was talking about in terms of creating an environment of inquiry, really encourage residents to get involved in research opportunities. And I am going to turn it over to Danielle for a quick minute or two, so she can just really quickly talk about her experience on the physician scientist track.
Hi, everybody. I'm going to keep this super short. I will say now I'm a PGY4. I came in as a new PGY2, which meant my second year was a bit compressed with getting a lot of psych in there. So what I found is that the research opportunities in the department, the faculty members who are providing them are amazing. I've had a universally positive experience with everybody that I've talked to, everybody I've asked for guidance and support. And, you know, and I think the things that they're transitioning into for the research track is really that protected time. And because that is something that there's kind of been a dearth of up until this point in PGY4. So that is something they're working towards. And I think, you know, this is a good plan if you are planning on having a career in research. And that doesn't mean like completely in research, but just, you know, if you want to incorporate research into your career, it is, I think it's a good idea. So, and if you have questions, please email me or, you know, contact me, however, and that's, I think, it.
Thank you, Dr. Farrar. Thank you, everybody, for tremendous presentations and a whirlwind through the education programs and division. And we will see you hopefully all again in 2 weeks. Again, we're not meeting next week. We'll see you in 2 weeks.
Great job, Dr. Katzman.